Previously on Dr. Boyev Talks at You.
Again, we have 4 pumps. We have the sodium acid countertransport. We have sodium potassium going the same way in the loop. We have sodium potassium going the same way in the distal convoluted tubule. And then we have sodium potassium countertransport. This is all the nephron physiology you really need to know for pharmacology. We're going to talk about 5 different classes of diuretics. The first 2 are not really used for hypertension per se, but we'll mention them anyway. The first one is a class of diuretic that blocks this sodium acid pump, and that's the carbonic anhydrase inhibitors. And carbonic anhydrase is an enzyme that's important with the way that protons and CO3 minus are balanced inside and outside of the cell. The representative drug for carbonic anhydrase inhibitors is acetazolamide or Diamox. I used to use Diamox a lot as an ophthalmologist in the emergency room because it reduces the pressure in the eye, because you also have a pump like this in your eye. So if somebody came in with a high eye pressure, you could give them Diamox. It would get the pressure in their eye down quickly. It will reduce your pressure in your bloodstream as well, because it does get rid of fluid, but it is so important to get rid of acid from your body that you build tolerance to carbonic anhydrase pretty quickly. So it's not really that useful as a long-term treatment for hypertension. Now, it turns out that it's good for getting fluid out of your eye, and it's good for getting fluid out of your brain. So it's a good drug for using for altitude sickness. Now, I live in Illinois, which is very flat. So altitude sickness doesn't come up that often in Illinois, but if somebody's going mountain climbing, it might come up. Altitude sickness is a condition where fluid builds up in the brain. You get brain swelling, which is what kills you. And in fact, I am told, I've never been there, but I'm told that if you climb Mount Everest, the tallest mountain on the planet, there are signs as you go up that say, if you're getting a headache, turn back. And evidently there's several hundred climbers that are frozen with altitude sickness that died because their brain swelled up. If they'd only had some Diamox with them, maybe they would have lived. The next class of diuretics to mention is the osmotic diuretics. And so now we're going to talk again about those sugar alcohols and sugars. So one very common osmotic diuretic is glucose. So you're going to see glucose playing a part in diabetics. So diabetics will spill extra glucose into their urine. And by spill, what I mean is a diabetic might have lots of extra glucose in their bloodstream if their glucose gets very high. And again, your bloodstream strains all the blood into the nephron and then takes back what it wants, including as much glucose as it wants. And all the extra glucose stays in the nephron. Well, that glucose has more osmotic pull. In other words, it sucks water harder than sodium. And so the water will follow the glucose out, which is why diabetics with high blood sugars tend to urinate more, what's called polyuria, right? So they urinate more because the glucose is acting like an osmotic diuretic. Similar, we can use sugar alcohols like mannitol and glycerol to get rid of extra fluid if we need to. Now, here's a quick question. What if you gave somebody mannitol orally? What would happen? Pause the video and think. The answer is that patient would have terrible, terrible diarrhea, because what would happen is, since water sucked towards mannitol in toward the lumen of the GI tract walls would stretch, that would stimulate movement, and then the patient would have terrible, impressive, explosive diarrhea. So osmotics that are taken orally act as laxatives. But mannitol is given IV, and mannitol can be used to get fluid off if somebody has, say, edema in their brain, and it can work very well for that. You don't use it now for something like heart failure, and the reason is that mannitol, if you give it IV, think about it. Imagine you have a patient with heart failure and they have acute heart failure and they're having trouble breathing and they only have a tiny bit of lung that isn't filled with fluid, and they're like, and I'll tell you, I think the second most frightened person I've ever seen was a woman having acute heart failure, because it's scary to drown in your own lungs, right? So it's scary. So a person sitting there, they're sitting up, hopefully you've sat them up, and it's hard for them to breathe because they only have a tiny bit of lung that isn't filled with fluid, right? So you give them the mannitol. Don't do this, but imagine that you gave them mannitol and it went in their IV, and it goes to their vena cava, right? And then it goes to their right heart, and then it goes to their lungs, right? So here's this mannitol, which is this giant osmotic sucking source. And it just sucks fluid with it as it goes through the blood vessels. So remember, your lungs are just like these delicate fronds of capillaries and alveoli, little tiny bubbles of air and little tiny capillaries of fluid. And what you've just done is put a molecule into those gentle little capillaries that's sucking fluid with it from the rest of the body. So it's like sucking fluid from as it goes through the arm, and it goes into your right heart, and it sucks all this fluid, and the fluid all just goes into your lungs. And that person only had a little bit of airspace already, and now all that fluid just like squeezes the airspace out, and you've killed the patient. So mannitol is no good for acute heart failure, but good for getting fluid out of your brain or your eyeballs or something like that. Okay, so mannitol is one of those drugs that's contraindicated in heart failure. You know that's going to be on a test, right? Just make a star. Let's get to the good stuff. Now I'm going to talk about the most important side effect of these three important classes of diuretics. The loop diuretics, the thiazide diuretics, and the poorly named potassium-sparing diuretics, okay? And the important thing to remember is which way the diuretics make your potassium go in your bloodstream. All right, so let's work through this. Okay, so first, loop diuretics. Now, as I mentioned, loop diuretics, and the most common one you're going to see is furosemide, or Lasix is the old trade name. It's even if it's not named Lasix on the box, people will call it Lasix. It's like calling a facial tissue Kleenex or calling a copier a Xerox machine. It's just a word that's sort of turned into a common word. So say you give somebody Lasix, a loop diuretic, okay? So that's going to block, I'm going to draw a big X. So it blocks the normal action of sodium and potassium being brought back into the bloodstream. So what happens to the sodium and potassium now? Where does that sodium potassium go? Does it go into the bloodstream or does it go into the nephron? That's right. If you block the normal action, the potassium is going to go out into the urine. So what's going to happen to the levels of potassium in the bloodstream? Are the levels of potassium going to go up or down? That's right. The levels of potassium are going to go down. Okay? And the word for that is hypo, meaning low, K, because who can write potassium? It's too long. It's just too time consuming. And then emia, which is the suffix meaning bloodstream, right? Hypokalemia is the medical term for low potassium, okay? So again, it's hypokalemia because nobody can be bothered to write hypopotassiemia because it's just too hard to say. All right, so hypokalemia. All right, so because the loop diuretics are so powerful, the hypokalemia that is produced by Lasix or other loop diuretics is pretty impressive and can happen quickly. Not for all patients, but if it happens, it's going to be impressive hypokalemia. Okay, now let's look at the thiazide diuretics, and the one to know is hydrochlorothiazide, which would be easy to remember because it has thiazide in it, except that most people abbreviate it as HCTZ. So you have to remember HCTZ means hydrochlorothiazide. All right, so imagine that we block this pump. You know, that sodium and potassium, instead of being brought back into the bloodstream, it's now going to go into the urine. So what happens to the levels of potassium in the bloodstream? They go down, right? So once again, we've got low potassium, hypo, K, because we can't be bothered to write potassium, emia, meaning bloodstream, right? So low potassium in your bloodstream is hypokalemia, low potassium in your urine, which is going to be a rare thing to measure, but would be hypokayuria, right? Right? So those suffixes are important. So emia means in the bloodstream. Okay. Now, the very poorly named potassium-sparing diuretics. I don't know whose idea was to name it this, because what is it sparing potassium from? Well, let's figure it out. If we block this countertransporter, okay? So sodium is now not being brought back into the bloodstream, but it's leaving with the urine. So water normally would leave with it. What happens to the potassium if we block this? It's like the potassium stays in the bloodstream where it normally wouldn't, which means now we have potassium staying in the bloodstream. So with prolonged use of these potassium-sparing diuretics, you actually get high levels of potassium or hyperkalemia. Okay, so the first two, loop diuretics and thiazide diuretics, cause hypokalemia because they're blocking these, and potassium-sparing diuretics cause hyperkalemia because I guess they're sparing potassium from the deadly fate of going into the toilet. I don't know. Who named these? So stupid. Why didn't they just call them hyperkalemia-causing diuretics? That would have been so much better for everyone involved. There's three different sort of versions of these. There's versions that were specifically made to block this pump. And one of those would be something like triamptorine. And triamptorine, the things that I remember about it is that it causes hyperkalemia and it makes your urine turn blue. So, all right, so that's one type is triamptorine and similar drugs. Then there's the class of drugs that are aldosterone blockers or aldosterone antagonists, right? Because aldosterone normally stimulates this pump. So if you block the pump by blocking aldosterone, then you're going to have the effect of hyperkalemia, right? The other type of potassium-sparing diuretic is an ADH blocker. So ADH, which is antidiuretic hormone, finally a well-named hormone, but unfortunately some people call ADH vasopressin because ADH also constricts blood vessels. ADH also opens up these pores between the nephron and the blood vessels. And the pores are where the water follows the sodium normally. So if you block ADH, it blocks the pores, the water leaves, and that tends to make potassium rise as well. So the three types of potassium-sparing diuretics, the ones that just block the pump, which is the drugs like triamptorine, the ones that block aldosterone, like spironolactone, eplerenone, they're going to be steroid-type drugs, so they're ending with ONE, ON. Then there's the ADH blockers like conivaptan. So, knowing this, and again, notice I've just blocked out the beginning of this because all that I care about for blood pressure, not just diuretics, but in terms of the diuretics for blood pressure, are these three. So you might say, wow, that was a long way to get to just these three pumps and just hypo and hyperkalemia. Yes, I see what you're saying there. However, it's worthwhile knowing this because if you know that these two pumps, if you know that these two classes of diuretics are similar in this respect, in that they both cause hypokalemia, you'll also know that they also are similar in other ways. For instance, both drug classes, the loop diuretics and the thiazide diuretics, both cause gout for similar reasons that I don't want to go into. But they both can cause gout. What? That's weird, right? Also, contraindication for both Lasix and for HCTZ is sulfa allergies, not sulfur, but sulfa, sulfa being a type of antibiotic. So if a patient has a sulfa allergy, then both thiazide and the loop diuretic Lasix, they're both contraindicated. What? That's a weird thing, but now you only have to memorize it once because you know that these are connected in this weird way. How's that? Yay! And you already know that they both cause hypokalemia. For the loop diuretics, especially for furosemide, they can cause ototoxicity, oto meaning ear. They can cause hearing problems, so if you end up giving them IV, you have to make sure that you inject very slowly, especially in little kids. For hydrochlorothiazide, there's a weird catch-22 associated with that because it can cause increase in triglycerides and blood sugar. It can cause diabetes, which should remind you a little bit of the atypical antipsychotics because that could cause the same side effect. The hydrochlorothiazides, it's a weird catch-22 because HCTZ is often the first line drug for hypertension, and a lot of diabetics have hypertension. There was a recommendation that came out that said, oh, for your diabetics, use HCTZ, but be careful because it causes diabetes. So All right, so that's good to know. All right, and then for the potassium-sparing diuretics, be aware of the 3 different types of drugs, and be aware that there's a way to escape from the problem of the hyper and hypokalemia, at least when you're dealing with the thiazides and the potassium-sparing diuretics, because they're not as severe as the loop diuretics. So in theory, you could give the patient a combination of a thiazide and a potassium-sparing diuretic, right? And you could get rid of that problem with the potassium, because messing up somebody's potassium is potentially life-threatening, because if your potassium gets too high or too low, it can cause your heart to skip a beat. If your heart skips too many beats, you die in the extreme situation. There's actually some preparations of, for instance, triamptorine plus hydrochlorothiazide, where as long as the patients don't have contraindications to those 2 individual drugs, they can take the combination drug, and then, in theory, potassium levels won't be a problem. Lastly, I just want to say, keep the big picture in mind with diuretics, because diuretics do one thing, which is get rid of water from your body, as well as a few electrolytes, obviously. And so what are you doing when you give somebody a diuretic? You're dehydrating them. So any condition where dehydration makes it worse will make it worse. Like in pharmacology, lithium toxicity will be worse if you dehydrate them, right? In fact, a lot of drugs, if you dehydrate them, their toxicity will get worse, right? Because you're making them more concentrated in the bloodstream. Also, if somebody, say, has terrible diarrhea or vomiting, you don't want to make them more dehydrated. That would be bad. Or if they've got low blood pressure, that would be a contraindication for diuretics. It should be common sense, but sometimes when you're studying drugs, you sort of forget about the big picture. So don't forget about the big picture. All right, I hope that helped. I went through all that stuff to help you get the big picture so that you can have an easier time remembering the little details.